Hi, I'm John Mortimer, and I'm going to talk to you about a way of redesigning the health services so that they are really person-centred. And this is in line with the NHS 10-year plan and the other associated plans that have come out recently. A few days ago, I had a conversation with someone to discuss value and failure demand, and this is where our discussion went. If I ask someone how their organisation works, this is very often what they will describe. They will talk about the team, their manager, and what's important to that team. They'll also talk about the team's position in the organisation, and they'll usually send me a hierarchy diagram. I spoke to Kath Halliday. Now, Katharine is someone who is very experienced in the NHS. She's gone through all sorts of roles. But in the conversation that I had with her, I asked her to put herself in the position of a radiology manager. And then I asked her, what would be important to you as that manager? And this is what she had to say.
So there'll be the targets. There will be targets. And the targets are around waiting times.
Okay, good.
So that's the main thing. So the waiting times will be the way the waiting times are measured. There's a thing called the DMO1, which is a stick with which radiology departments are regularly beaten. And what that is the time from referral for a diagnostic test to the test being done. So the turnaround time is the time from the test to the report. That didn't used to be measured, but now it is measured. It's not something that's held on a national database, nationally, but it is important because the whole hospital will be complaining. If I'm running a clinic and none of the results are back, I'm going to be complaining at you the whole time. So,
what's in Katharine's head when she describes those KPIs? What do we notice about her focus? Now, her focus to me is that she is really looking at those KPIs as a way to manage. And that's what's important to her manager. When we look at what the KPIs are there for, they're there to drive efficiency within radiology. They're there to drive improvement so that year on year, there's going to be an improvement in their performance. There's going to be a focus on radiology as a service. This is all that I hear when I listen to Katharine. And I then try and figure out, how does she picture her service, her department? And I think that it's probably something like this, in that you've got inputs, you've got something that happens, and then you've got outputs. A bit of a sausage machine. But that's what radiology is all about. I then asked Katharine, what can she do about improving these KPIs? And this is what she had to say over both of those.
Number of staff, basically. Number of machines and number of staff. So there are sort of efficiency things you can do, and you can make sure that you're not giving them too long an appointment. Or, for instance, if they need to have a cannula inserted, you can make sure that you've got a fairly low banded staff to put that cannula in outside the room. Do you see what I mean? The patient's not lying on the scanner. So there is sort of, you can do all sorts of efficiency things to try and maximize the use of your asset and sweat your asset.
So the paradigm that she really has in her head is really one of a sausage machine. It's this picture of a machine metaphor, and radiology is just one small part of the whole health service in general. And there are lots of other departments and lots of other services. And if you look at their hierarchy chart, you'll see all of these with all their managers and directors and all of that. Now let's listen to Katharine, to what she has to say when we ask her about the effectiveness of what she's able to do.
So there are quite a lot of things that are done when there's a very low probability of finding something. And there are quite a lot of things that are done with nobody really having thought about the next step. What difference does it make to that patient? Teenage girls, for instance, having ultrasounds when actually it's probably not going to make a difference to the treatment options available to them. And people with little lumps and bumps, they're saying they want to know what it is. Well, it probably doesn't matter what it is. It doesn't make any difference. We're not going to do, the only option is to take it out or not. And that's the choice you have.
So you can see that she is trying to do her best to improve. And the only way that she can really do that is to focus on those people that really need a scan. And it really seems to be a problem when there are people coming through that don't need a scan. I then asked Katharine, what is she inclined to do to try and fix these problems? And let's see what she says.
Well, as an old-fashioned radiologist, what happens is a request will come through to me. So all the requests for an ultrasound scan, for instance, are vetted by me. So I will see, it says 14-year-old heavy painful periods, ultrasound, question around. And I will say, I will reject it. I will say, I'm not doing it. I don't think this is indicated and I don't think it's going to help.
So that's what Katharine is inclined to do now, to focus on her KPIs. You can see how the pressure on her service is driving her to do this. What I found interesting was the fact that she's got a problem and she's solving that problem. From a systems thinking point of view, that's a single loop analysis and problem solving. What it isn't is double loop, which is talking about the cause of why this happens. She's just going and rejecting those scans that she thinks are inappropriate. Listening to Katharine, I wondered how this attitude would impact other departments. The thing that were going on in my head was that this is probably going to drive barriers between her and those other departments. It's going to drive competition. It's not going to drive collaboration. It's going to reduce the communication between different departments. It's going to develop mistrust. It's going to promote a lack of relational working. It's going to focus on going back to the rules and regulations of what radiology is really there for, and the performance and behaviour of Katharine is probably going to be called into question. Now, is this actually going to improve or reduce efficiency overall? I then wanted to know what Katharine thought this was actually going to drive, and this is what she said.
Awful, I think. And
pissed them off.
Yeah, really pissed them off and makes them look ridiculous in terms of the patient and generally. And then the question is, why do they do it? Why do they do it? Sometimes they do it because they've only got 7 minutes and they think, it's actually easier to request the test than to make an explanation.
So what might happen to Katharine? Let's have a look at the departments that she's in relation to other departments. On the left, we have the people coming in that need help to the GP. They may actually come into A&E or other departments, and that GP will create a referral to radiology. Now, because of Katharine's approach, some of this is going to bounce back to the GP, and then there's going to be toing and froing from one to the other. The GP might decide to get oncology there, so they try and put some pressure on Katharine, and Katharine doesn't like that. And then, of course, the GP has to tell the patient what's actually going on. The director sees this and thinks, right, what I'm going to do is to help Katharine to have better communication and better contact with the GP. So there's all sorts of things that the director can do, different types of training and group sessions and works. And can you imagine Katharine doing that, what her attitude would actually be? And also the attitude of the GP. Is that going to fix the problem that we have? I don't think so. So I don't think it's going to improve. But what's really interesting, I think, is going back to an understanding of what's driving this. And I believe it's the KPIs and what's important to Katharine has been given to her about improving her department. Now, could you imagine this happening across different parts of the public sector, or at least different parts of health? You've got all these departments and all these services perhaps set up in very similar ways. Now what we're going to do is we're going to have a different perspective on what's going on here. And we're going to start with the demand. What is the demand itself? Well, if we were in the doctor's surgery, we would hear that as being, I need a scan. Let's go a bit further into that, shall we? And let's have a look about why someone would say, I need a scan. So a mother comes in with a teenage daughter, and we find out that what really matters to her is not just that she needs a scan, but actually there's been some talk going around at school where they heard that someone of her age had pain, and actually she ended up having a tumour. And now her and her friends are really worried, and that's why she's come to the GP. What does this drive the GP to do, and why? Well, the GP's only got a certain number of minutes, and very often the GP is there to deal with the demand that's in front of them. And because they've only got 7 minutes, they then have pressure to make a decision on what to do. So some GPs will make a referral to get a scan done. And the other thing that happens actually is that there's a bit of risk avoidance here, because can a GP diagnose this situation in the amount of time that they have? In my head, the question was, what is the correct approach for a diagnosis in this situation? Well, remember that diagram that we just looked at? Let's have a look at a slightly different diagram. Let's start with where the demand comes in and what matters to the people that come in to see the GP. So this is a different perspective. Let's look at the person and their life in their context. What might be the right method of diagnosis here? Well, actually, it's to do with the school, with friends, with social media. That is, if the GP has the ability to listen and to understand the whole context of what's going on. Now, if that GP was able to, maybe they would then say, actually, what I need to do is go and focus on the school, friends, and on social media. That would be one way of dealing with this demand. Another one would be to go through and ask for a scan for radiology. That would be another treatment. So by understanding what matters, we actually discover the real demand, and it allows us to make a different diagnosis and then drive to different types of treatments. When we do this, we're looking at radiology from a different perspective. Instead of being the perspective of the director and the manager in radiology, which is a vertical perspective, it is now a horizontal perspective that we're uncovering. It starts with the person coming into the GP. It starts then with understanding what matters, and then the decision is made there on what to do next. The focus of the service has now changed. The attention is the horizontal, not the vertical. Just before I move on, I'd like to ask a question about the current way of working with a vertical focus. What's the purpose of that focus? I didn't ask Katharine this, but I think if I did, she would have said something like, to deal with the requests for scans. What would be her answer to the question in the horizontal service? Perhaps the purpose then would be to help the people in need using appropriate diagnosis and treatment. Some of that may be radiology, some of it may not be. When I had this discussion with Katharine, this is what she had to say.
I would give the GPs much longer to do shared decision making, to really understand what is important to that patient. Because I don't think she's worried about whether she's normal or not, maybe a bit. I think she's probably worried about that horrible pain in her tummy.
So what have we done with Katharine? All we've done is change it from a vertical to a horizontal, and she's come up with a different way of engaging with the GP and a different way of looking at her service. It's not so much her service anymore, it's now a horizontal service that's different to what it was before.
So, I mean, this is a really good GERFT principle, that what you would do is you look at all these A&E departments.
Yeah.
And you start off with the data and you say you flipping refer twice as many people for CT head.
Yes.
And then you go into the department. So this is the girl principle. You take it back to them and you say, okay, this is you, this is everyone else. Let's sit here and work out how we can do this.
This was part of a discussion that I was having with her about value and failure demand. If we defined value demand, which is the demand the service is designed for to provide a good service, if we look at the horizontal service, the demand is something like, I'm anxious. The failure demand is the demand that the service causes the person to make, a failure to do something right for that person. We might translate the demand as, I need a scan. Failure is defined by the system design directing inappropriate decisions. It's not the fault of the GP. It's not the fault of Katharine. It's the way that we have designed the way that the system works. If we modify that, then the behaviour of Katharine and then the behaviour of the GP would be quite different. So this is how we can interpret the use of value and failure demand. Value and failure demand itself came from contact centres and front office, back office service organisations. So what we've done here is modified a little bit because it's actually not a method, it's a series of concepts. And you can see here the impact that it's actually had. Let's have a look at what value and failure has helped us to do. The first thing it did is it's given us a different perspective. And I like to call that an outside-in perspective because it's given us a perspective of the person that's coming in who needs help. The customer, the user, the patient. It's their perspective that we're starting with and their perspective that we're allowing the design of the service to be created by. So then it allows us to redesign our service in that way. And it's changing our thinking. It's changing the way that we understand not just our service, but how health works. So just in this one conversation that I had with Katharine, that was a really powerful discussion. And if we look at a different health system, we're now looking at it end to end from the patient's perspective, from the very beginning to the very end of the treatment. And for different people, it will be a different path. It will be focused on what matters to me as a person in the context of my life. So instead of improving in the vertical direction radiology, we're now going to improve the horizontal, which is the end-to-end. Now, can you imagine what Katharine can do now together with the GP to improve that service? Very different to what she was focusing on at the beginning of this discussion. So what she actually wants to do now is to cooperate with GP and A&E and others and work together with them to find out what works best. Lastly, imagine the role of Katharine changing from being just the manager of radiology to actually focusing on the end-to-end. How different would that be? And what a different perspective that would give her. It would give her the ability to have a far broader understanding that would have group ownership and responsibility with other parts of health. And lastly, what that does, of course, is then begin to focus on the determinants of health, if you take it to a wider perspective. And it's not actually Katharine that is behaving this way. It's the system that's driving her behaviour. And you can imagine the impact that that would have on the effectiveness and the efficiency of the whole of that service and the impact on the cost. Now, in my discussion with Katharine, she wasn't quite sure whether actually costs would go down. But I've done this work many times. I want to use an example from what a group of people did in Thurrock. They had a very similar approach to how I described, and they worked with a group of people who were in particular complex needs. They had mental health issues together with other issues as well. And what they did is that they went back 1 and 2 years and tracked the cost to the public sector for that cohort of people. And that graph that you can see now is the total cost for those people. Then at this point, a team took over that worked in the way that I've just described. They focused on the horizontal, they focused on the end-to-end. They worked together as one team instead of separate departments and separate silos. And they were given permission to be flexible, to work with the demand and what matters to each of those single people differently. And very often this meant, instead of talking to them via online forms and assessments, what the team did is actually go out and talk to them in the context of their homes, where they were. Some of these people were homeless. Now, that involved a lot of work, and Katharine was going, I think that's probably going to increase costs, isn't it? Because that doesn't sound very efficient. But what the team did over a period of time, and they worked firstly for 1 year and then 2 years with the same cohort of people, what did we find about the cost? Well, this is what happened. For that cohort of people, the cost dropped significantly. And what they found is that in 1 year, they were able to reduce the cost that they would have spent by £54,000 per person. That's the impact that's possible if we're able to redesign the service in a different way and allow those people in the service to decide themselves what path they should take. So before, Katharine was possibly seen as awkward and as a blocker. In this new approach, actually, Katharine would be far happier working in there, and she would be cooperative and wanting to improve. What underpins this is systems thinking, complexity, and designing around both of those things. What's absolutely fascinating is that in some ways, that switch in perspective can be quite simple, but it leads to huge fundamental change. And you can see the impact of that change. That's what value and failure demand concepts does. That's what systems thinking concepts do. So this is a way to apply the new thinking of the NHS 10-year plan into looking at a wider health service, the whole system of health. This changes behaviours, this changes management approaches, this changes the way that we're structured, and interestingly, it starts to link all of those together to actually start to focus on the determinants of health. And if you go wider, you start to focus on bringing in those aspects of the public sector and communities which can now focus on prevention. So that's what I do. And that's the result of the conversation that I had with Katharine. I hope this was helpful for you. I've got some more details in the description below and links to other places where you can get some more information. And if anybody has any more questions, please don't hesitate to get into contact with me directly. Thank you.